The following podcast is part of a certified educational activity featuring Ruben A. Mesa, MD, FACP, from Mays Cancer Center at UT Health San Antonio, MD Anderson, and Jean M. Palmer, MD, from the Division of Hematology and Oncology at the Mayo Clinic. Access the entire activity and complete the post-test at peerview.com/MME860. Downloadable slides and practice aids are also available.
Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio, MD Anderson. And it's a pleasure to welcome you to this session on how to manage JAK inhibition in patients undergoing hematopoietic stem cell transplant, applying the latest clinical evidence to improve patient outcomes in myelofibrosis. I'm joined today by my good friend and colleague, Dr. Jean Palmer from the Mayo Clinic in Arizona. So we'll go ahead and begin, and we're going to be focusing on a few different areas. First, on the modern prognostic scoring systems and JAK inhibition in myelofibrosis, taking a closer look at the evidence of the innovation behind these. Second, innovative strategies for refining and expanding the therapeutic role of JAK inhibitors and stem cell transplant in myelofibrosis, particularly this being a meeting that focuses around transplant. How do both medical therapy and transplant interweave for myelofibrosis in 2021? And then finally, we're going to have some insights on the clinical implications and practicality of managing JAK inhibition around the peri-transplant settings. So first, let's jump in and talk about setting the stage for understanding prognosis and where JAK inhibitors fall in. Now, as we think of myeloproliferative neoplasms overall, our focus today is really around myelofibrosis. There's patients with earlier MPNs, PV, ET, early MF. Here, the risk are symptoms, potential splenomegaly, risk of vascular events. But it's myelofibrosis that is the most severe of the MPNs, whether it be primary or post-ET or post-PV myelofibrosis. Patients have burdens of splenomegaly, symptoms, potential cytopenias. They can progress to acute leukemia. They can die prematurely from the disease. But their disease course is quite heterogeneous. Patients can have a lot of difficulty with these burdens. Splenomegaly in the majority. Many have symptoms, in particular fatigue, but many constitutional symptoms, potential cytopenias, and many have a premature mortality associated with the disease. Now, diagnosing the disease, particularly primary myelofibrosis, but each of the three subtypes of myelofibrosis arise from the WHO criteria. They involve both major criteria that include bone marrow histologic features. They include clearly not having an alternative myeloid disorder, and typically the presence of a driver mutation, JAK2, CALR, or MPL. There might be individuals that lack one of those three mutations, and we'll get around to those in a moment. They may have a worse prognosis. But important, they also require potential minor criteria that give you a confirmation of the clinical scenario, cytopenias, splenomegaly, symptoms, etc. Now, over time, our testing has become more sophisticated. It clearly includes histologic features of the bone marrow, trichome stain, reticulin stain to look at fibrosis. Karyotype is very helpful and helps us in prognosis. And now molecular testing, both for driver mutations, CALR, JAK2, MPL, as well as, in particular, as we're deciding around transplantation, NGS panels for myeloid mutations have really become standard. Now, if you're considering transplant, these would be standard of care. Now, because of the heterogeneous nature of these diseases, there have been many efforts to develop prognostic scoring systems. One that has been the most widely used globally has been the DIPSS or DIPSS Plus, that look at age, symptoms, blood counts, presence of blasts, and help to define a risk score that helps to predict survival. In the DIPS Plus, we also weave in additional negative prognostic implications of an adverse karyotype, with examples you see on the right of the slide of some of those adverse karyotypes, thrombocytopenia or red cell transfusion. You'll see that many of these features are not that distinct from prognostic scoring systems for MDS or CML. And it's somewhat logical when we think about it, in that those, again, as myeloid diseases, drivers of mortality can overlap. Now, the driver mutations that I've mentioned are important both in diagnosis but also prognosis. Individuals that lack all three of those driver mutations have the most adverse prognosis and tend to have a higher number of additional somatic mutations. Patients with calreticulin probably have the best prognosis in that group, with JAK2 and MPL being more in the middle. Now, with calreticulin, there are two types of calreticulin mutations. One is the more common and more favorable prognostically 52 base pair deletion. There is a type 2 mutation. It is less common, but it's an insertion that actually has a worse outcome. So all of you as transplanters at this meeting in particular, distinguishing between these two is very important in terms of their prognostic implications. Indeed, you see the difference in terms of survival. Now, what about non-driver mutations? We call these non-driver mutations because the other three tend to be mutually exclusive and have the most solid case in terms of driving disease development and progression. But these other mutations that you'll also be well familiar with from MDS, from AML, from advancing myeloid neoplasm, are ones where, again, we see in particular in myelofibrosis, and some of which can be negative drivers of prognosis. Trying to weave these mutations into the mix have led to the development of the MIPSS and MIPSS 70+ scoring system, which gratefully, there is a website that you can use. You can log into this website, simple to use, put in the clinical data that now includes whether there's a high-risk molecular feature, ASXL1, EZH2, SRSF2, IDH1 and 2, or greater than equal to 2 of those. And there we can refine prognosis to a greater degree than we could with the prior scoring system. There's now an additional MySec-PM, a nomogram which weaves in both these features as well as age, and can be helpful for you as the transplanter or working together with the team. Jean and I, that frequently have worked as a dyad in terms of managing patients with myelofibrosis, will discuss in the cases how we try to assess prognosis in the setting of decision-making for transplantation. Now, the NCCN guidelines, currently led by Aaron Gertz, I had the pleasure of being the inaugural panel chair, has divided up in terms of our decision-making, patients with lower risk disease or higher risk disease. And again, regardless of which system you use, can help stratify in one of those two groups, depending upon which testing you have available for you. Now let's pivot a bit toward therapy. As I share with patients with myelofibrosis, there's fundamentally 3 different approaches: observation, optimal medical management, or stem cell transplantation. So how do we weave these 3 together? Well, if we think at a high level in terms of the NCCN guidelines, we've got low-risk patients, and if symptomatic, maybe receive therapy, JAK inhibition, such as ruxolitinib. Intermediate 1, again, symptomatic ruxolitinib. Some individuals, perhaps stem cell transplant. We'll get around to that differentiation in the cases. Intermediate 2 and high risk, stem cell transplantation, an important consideration. Those not going on to transplant right away, we consider JAK inhibition, and depending upon the platelet count, may consider ruxolitinib and or fedratinib. Now, how did we get to this point? Well, let's go through some of this data. So first, ruxolitinib has been the standard of care for almost 10 years now on the basis of the COMFORT-1 and COMFORT-2 study that showed clear superiority to either placebo or best alternative therapy for improvement of splenomegaly and symptoms in patients with myelofibrosis. And importantly, it also has yielded an improvement likely in survival. And although these studies were really not designed for that, every subsequent analysis, retrospective analysis, even looking at patients of the last decade, helped to confirm patients live better, but they do live longer. And that may be lower likelihood of progression, less debilitation, less morbidity from the disease. We have learned many things over time, including dose intensity and the degree of splenic reduction are predictive factors in seeing who has a survival advantage. So optimizing dose and using enough of the therapy is key. Now, we have learned that individuals that fail ruxolitinib have a poor natural history, in particular if they have had clonal evolution. There's been great interest trying to understand what it means to fail ruxolitinib through progression, resistance, intolerance. Now, as I've shared with many individuals, failing a drug is somewhat dependent upon the other options that we have. So we have had to consider if an individual has progressive splenomegaly, symptoms, cytopenias, leukocytosis, or increase in blasts, what approach do we undertake? Do we increase the dose if the spleen is not responding enough? Do we switch treatments if the symptoms are no longer getting better, or bring in another therapy? Do we add another therapy to improve anemia or to control leukocytosis? Or if they're moving toward acute leukemia, do we go a different way? Transplant, hypomethylating agent, venetoclax, etc. Now, an important additional option has become available for us and now approved in September of 2019, fedratinib, oral JAK2 and FLT3 inhibitor, and it was approved on the basis of the JAKarta study, where individuals received either two different doses of fedratinib or placebo in a 3-arm study, and it showed significant superiority for control in both spleen and symptoms for individuals being treated with fedratinib, as well as superiority of likely fedratinib at 400 milligrams when looking at both safety and efficacy, which is now the currently available dose and recommended dose. Here you're seeing on the JAKarta study, the spleen response rates. In a recent analysis that we did at last year's ASH, we looked at individuals treated at full dose with moderate thrombocytopenia and saw strong response rates at full dose, which we would have people consider as one of those niches for frontline use of fedratinib. In terms of toxicity, there can be GI toxicities. It's manageable. I now have treated many patients off study after its approval. I give them some PRN Imodium, some PRN Zofran. Many don't need it or come off of needing it. There are some rates of anemia and thrombocytopenia that are manageable. Now, we've looked at it in second line as well. And in an updated analysis of the second line study that Dr. Harrison and I and others had conducted, we see a 30 or so response rate with a stringent modern criteria in terms of definitions of ruxolitinib failure and assessment of response. These results are being validated in the current freedom studies that are accruing. Now, possible algorithms for treating myelofibrosis after failing JAK inhibitor therapy. So first, if you failed a JAK inhibitor and transplant is an option, that is an important consideration. But how you fail the JAK inhibitor is part of the equation. If you just were intolerant and the disease is no longer higher risk, I'd be much more inclined to use a alternative JAK inhibitor, switch from ruxolitinib to fedratinib. Or did they not have sufficient ruxolitinib to have an adequate try in terms of the dose? Or have they been on it for 3 years and have now progressed? Likewise, clinical trials are always an important consideration. Now, the JAK inhibitor landscape is robust in addition to ruxolitinib and fedratinib. There's pacritinib and momelotinib in advanced phase 3 programs, and a variety of other JAK inhibitors which have been tested. Momelotinib currently accruing in the Momentum study that Dr. Rostopchik and I are leading, and that is a second-line study. Prior studies showing a good efficacy for improvements in splenomegaly and symptoms, as well as potential improvement in cytopenias, with momelotinib in the frontline setting in Simplify 1 and second-line in Simplify 2. Pacritinib having good activity for individuals with marked thrombocytopenia. In addition to inhibiting JAK2, it has activities against IRAK1, and this may be part of its benefit. It's very helpful in this myelodepleted phenotype of individuals with marked thrombocytopenia. Now, at the current time, we have a very robust set of agents in development for patients with myelofibrosis. A variety of different agents alone or in combination with ruxolitinib, and potentially that may be able to be combined with fedratinib. Cell cycle checkpoint inhibitors, anti-fibrosing agents such as PRM151, receptor antibodies, signaling tyrosine kinase inhibitors. I mentioned the JAK inhibitors. We have the MDM2 inhibitors, such as idesinutlen, navitoclax, the BCL2 inhibitor. We have immunomodulatory drugs and a variety of histone deacetylase or epigenetic modifiers like the BET inhibitor. Indeed, at this year's ASH, good data from the combination of navitoclax plus ruxolitinib showing efficacy in high-risk populations with patients with relapsed or refractory myelofibrosis. They're showing activity both in high risk by molecular features as well as high cytokine profiles. And that has led to 2 studies that are launching, both the Transform 1 study, which is navitoclax plus Rux versus best available therapy in patients with myelofibrosis. So this is either in combination versus Rux as single agent, or this second-line trial of navitoclax plus Rux versus best alternative therapy, again, looking for optimization for that group. As we look at frontline therapy, again, we have, in a non-scientific manner, these are just raw data. These are not randomized between them, but the 4 JAK inhibitors as single agents on the left. And we're now pivoting to potential combinations, where we saw at ASH the combination of the Constellation agent, the BET inhibitor plus ruxolitinib, showing, at least in phase 2 data, impressive upfront efficacy numbers. Now, as second-line therapy, we're again seeing good results in the phase 2 with navitoclax plus Rux or the BET inhibitor plus Rux. And then you see a variety of other agents in the second-line setting, Jakarta 2, the IMG 7289, imidostat, and even single agent of the BET inhibitor. We're expanding our awareness of new endpoints. And on the right, you'll see new endpoints, improvements in fibrosis, molecular phenotype, progression-free survival, overall survival. These are boxes that are still being filled in that will need really from phase 3 studies. But we're expanding our repertoire beyond splenomegaly symptoms and anemia as possible areas of efficacy. Indeed, as we try to come toward a consensus of treating MF in 2021, it's a balance between how do we optimize those medical therapies that I've discussed based on risk and the evolution of clinical cases, and then how do we weave in the potential of an allograft. So that helps to set up the discussion and the points of where we weave in transplantation. With that, why don't we pivot toward the issue of transplant before we try to bring it all home together. Dr. Palmer.
Hi, well, thank you very much. And you set the stage beautifully for what I hope to talk about today. And what I would like to do during this talk is to review the process of transplant in myelofibrosis, as well as review the role of JAK inhibitors around that. So first, I wanted to show trends in survival after allogeneic transplant for myelofibrosis or myeloproliferative neoplasms. And this is a slide from the CIBMTR looking at just survival trends, not taking into account some other factors. And you'll see back in between 2001 and 2005, which is the blue line here on the bottom. The green dotted line is 2006 through 2010. And then the orange dotted line on top is from 2011 to 2017. Number one, the number of transplants has been increasing substantially. I think with the fact that it's really recognized that this is a really good therapeutic option for it. And the second thing is you'll see improved survival. So the probability of living and surviving a transplant has also gotten better. And I think this is both a combination of taking patients in earlier as well as understanding some of the complications of transplanting these patients. So to start with, these are the recommendations from the EBMT ELN regarding patient selection. First of all patients with intermediate 2 or high-risk disease according to IPSS, DIPSS or DIPSS plus and less than 70 should really be considered for allogeneic stem cell transplant. If a patient is younger, i.e. less than 65, has intermediate 1 risk disease and has features such as high-risk mutations, peripheral blasts that are greater than 2%, transfusion-dependent anemia, these are patients who should also be considered for transplant even if they don't meet the DIPSS criteria. Low-risk patients should not be considered for transplant and they should be monitored. Now, clearly, as we know, this does not fit all patients, and we'll review sort of some of the caveats as we move forward. So what are the considerations for transplant and myelofibrosis? Pre-transplant, we worry about what do we do about splenomegaly? How do we improve constitutional symptoms, and how do we select an optimal donor? For transplantation strategies, it's patient selection. Which risk scoring system should determine the timing and the conditioning regimens used? And for post-transplant considerations, we want to look at prevention of relapse as well as long-term outlook and quality of life. So this study was just published last year, and it was a registry study that was comparing CIBMTR data along with a registry that was created from 14 academic centers on patients who did not undergo stem cell transplant. And there were 500 patients in the transplant arm, and this was data collected between 2000 and 2014. And there was over 1,300 patients in the non-transplant arm. The median time of follow-up was 72 months for transplant and 63 months for non-transplant. And it is notable that ruxolitinib was used in about 10% of patients who underwent transplant and 30% of patients who did not undergo transplant. And what we see here on the graphs is graph number A is low risk, graph number B is intermediate 1 risk for DIPSS, graph number C, or graph letter C, is intermediate 2 risk, and graph D represents high risk. And you'll see with low risk disease, there's definitely a survival advantage to not performing transplant up front. However, when we get to the intermediate 1, intermediate 2, intermediate 3, transplant seems to be the winner in this setting, although it is notable that there is a decline in survival, especially up front with transplant, which is expected. So what are some modern outcomes? This is the EBMT registry study that had a median follow-up of 4.7 years, and this was done on all patients transplanted for myelofibrosis. 47% of the patients died. The rates of graft versus host disease, both acute and chronic, are fairly expected, and disease progression occurred in 26%. Graft failure is only present in 7%. The median survival of these patients was 5.3 years. And again, this is with a median follow-up of 4.7 years. Factors that impacted overall survival included age, graft failure, grade 3 to 4 graft versus host disease, and a KPS of less than 90%. Non-relapse mortality, grade 3 to 4 graft versus host disease. Interestingly, ruxolitinib did not impact post-transplant non-relapse mortality. And then with regards to what predicted relapse, it was intermediate 2 and high-risk DIPSS, and any graft versus host disease appeared to reduce the risk of relapse in patients. Another way to try to predict transplant outcomes has been done by our colleagues at City of Hope, and they looked at 110 patients that they transplanted using fludarabine and melphalan conditioning. And they tried to determine what would predict outcome. Interestingly, when it came down to predicting the outcome, these single mutations that have been detected, the mutations that Dr. Mesa had reviewed in his talk, did not seem to predict outcome by themselves, but if you used a composite MIPSS score, that was associated with non-relapse and overall survival, suggesting that it probably is not one factor that contributes to how patients do, but a combination of them put together. And then finally, this is a system that was derived through the EBMT. And what they wanted to do is not only take into account clinical factors of the patient, but also take into account things like what their donor situation was and what their performance status was. So they found 7 clinical, molecular, and transplant-specific independent factors that predicted survival, and a 4-level system that predicted survival and non-relapse mortality. This was applicable to both primary and secondary myelofibrosis. And these are the factors that they identified and how they were weighted. So as would be expected, leukocyte count, platelet count, performance status, absence of CALR, MPL mutation, age of greater than 57, HLA mismatched, and ASXL1. So again, some unique aspects of this are taking into account what the donor situation is as well as the performance status. And what this did was this found that based on the scores that we added up, that you would be considered low, intermediate, high, or very high risk for transplant and have a survival that would reflect that. So then they said, well, how does this compare to all of the other scoring systems that have been created? And they found that the MTSS, using this analysis, was a very good system that had optimal performance. So how do JAK inhibitors fit into this transplant continuum? So when we look at the NCCN practice guidelines, the intermediate 2 or high-risk myelofibrosis bridging therapy can be used with JAK inhibitors to decrease spleen size prior to allotransplant. And in patients who have accelerated phase, one must consider using hypomethylating agents hypomethylating agents to reduce the percentage of blasts prior to moving forward with transplant. So as we think about transplant, one of the things that we must consider is what to do with the spleen. So splenomegaly is very prevalent in patients with myelofibrosis and of concern, as having a large spleen could potentially impact engraftment, as well as impact the recovery of blood counts. And there was an EBMT registry study that looked at over 1,000 transplants. 202 of these patients had splenectomy. When they reviewed these patients, they did a few different analyses. First of all, they said, well, does having a splenectomy make a difference in overall survival, non-relapse mortality, or relapse? And it didn't. Then they looked at, well, what happens if, do we have a difference in survival between patients with spleens less than 5 centimeters, greater than 15 centimeters, and 5 to 14 centimeters? And those are the 3 on the bottom. And they found that there were trends towards improved overall survival when a patient had a small spleen, and a trend towards improvement in relapse risk. However, non-relapse mortality wasn't significant. Then what they did was they isolated this to those patients who had spleens greater than 15 centimeters. And in that case, they found that taking out the spleen prior to transplant improved overall survival, resulted in a significant reduction in non-relapse mortality, and there was no increase in relapse risk. So it did show that there's potentially a benefit in those patients who have particularly large spleens. As we all know, another way to shrink the spleen prior to transplant is to use ruxolitinib. Initially, there was a concern that ruxolitinib pretreatment may negatively influence the outcome after transplant. However, this has been disproved in future studies that have been done. There have been quite a few reports listed in this table that show the spleen response to ruxolitinib, what the impact was on graft failure, graft versus host disease, and treatment-related mortality. And as we see with these studies, albeit most of them quite small, there have been good spleen responses noted. They were generally tapered off during the conditioning and not seemingly associated with any increase in the risk of graft failure. There was also no significant increase in the risk of graft versus host disease, which is another concern on tapering off the ruxolitinib just prior to transplant. And the treatment-related mortality was certainly not any higher than would be expected. A new approach has been tried to continue on the JAK inhibitor through the transplant rather than discontinuing it prior to transplant. Generally, when we discontinue it prior to transplant, it is tapered off directly before the patient starts the conditioning therapy or during that period. However, in this approach, they said, well, perhaps if we continue the JAK inhibitor through the transplant, we will avoid some of that cytokine rush that may result in increased risk of graft versus host disease. So there's a couple different studies that have been published or presented. First was a study that was done by the German group, and they looked at a very small number of patients, and they continued ruxolitinib through engraftment. Of note, it was a very small study, but there was no graft failures in this patient, and the median engraftment was 12 days, which is quite acceptable. There was another study that was done in patients who, again, a very small number. They all received fludarabine and melphalan conditioning, and they had impressive 1-year survivals, progression-free survivals, and non-relapse mortality. And this is in patients, they had 2 different dosing levels, and it was given from day -3 through day +30. All the patients engrafted, and there was quite acceptable levels of graft versus host disease and 1 CMV infection, suggesting it didn't particularly worsen their infectious risk or other complications that would be concerning with using ruxolitinib in this setting. Another factor that we have to look at is age and transplant. As we all know, we are transplanting patients at older and older age, but does the same thing apply to patients who have myelofibrosis? EBMT looked at this data, and they evaluated 45 patients who are above the age of 65 who underwent a transplant. Reduced intensity conditioning regimens were used in all these patients, and there's a median follow-up of 4 years. 14 patients died and 12 from treatment-related mortality. But it is notable that, that this is still what would be acceptable in the range of transplant, acceptable rates of graft versus host disease, and very comparable to a different study that showed a 41% 5-year survival in patients above 60, suggesting that age should not be a barrier to transplant. So right now, the EBMT/ELN recommendation is that JAK inhibitor therapy is indicated in patients with symptomatic spleen or with constitutional symptoms. And the recommendation is the drug that should be initiated 2 months prior to transplant and should be titrated to a maximum tolerated dose. A wean should be started 5 to 7 days prior to conditioning to avoid rebound phenomena, with the drug stopped just the day before conditioning. Following transplant, one of the big concerns is relapse. And as we know from relapse studies with both myelofibrosis as well as other diseases, there's many approaches that people can take. There was a study that the EBMT did looking at relapses after transplant, 251 relapses for patients with myelofibrosis, and many approaches were taken, including a DLI alone, chemotherapy and a DLI, a second transplant. And it did look like there was not a significant difference between all of these different approaches. So what happens to quality of life after transplant? I think one of the biggest factors that people come in questioning me about when they come in for a transplant evaluation is what will happen to their quality of life. Many people express the fact that they don't want to survive if it's not going to be a good quality survival. So we looked at this in a number of patients who underwent transplant. This was done through 2 different centers here in Mayo, Arizona, as well as a center in Germany. And we evaluated different patient-reported outcome measures such as FACT-BMT and MPN-SAF that were measured at baseline, day 30, day 100, and 1 year post-transplant. Interestingly, quality of life as measured by these scores did not significantly worsen over the course of a year. As would be expected, they did drop between day 30 and day 100, but at 1 year, they came very, very close to baseline. All of the MF-specific symptoms, such as pruritus, fevers, and spleen symptoms, did significantly improve, at least at one point following transplant. And at 1 year, when we did the patient global impression of change, 61% of patients reported they felt better than they did prior to transplant, suggesting that these concerns over quality of life, while valid, are probably not any quality of life is probably not any worse than it is for other types of transplants. So what's the outlook for these patients? What is the survival following transplant? This was another EBMT registry study, and they looked at almost 2,500 patients who received a first allotransplant between 1995 and 2014. And 1,000 of them were alive at the 2-year time point, and they did a landmark study starting at that 2-year. The 10-year overall survival and disease-free survival for these 2-year survivors was 74% and 64% respectively. In patients who were less than 45 years of age, the 10-year survival was 86%. Late relapse was the leading cause of death. The risk of mortality was increased in patients who were older, who had secondary myelofibrosis, who were male, and did not have any graft versus host disease before the landmark time measured. But this is very promising information for those who do undergo transplant, and shows very nice data that the survival, although it's not going to be that of somebody who has not had a transplant and never been sick, is still quite reasonable. As you see here, this is slides that are graphs that are reviewing survival of transplant survivors versus age-matched general population. And as would be expected, the survival is worse, but it is better than it would be had they not received a transplant. So what is the role of these newer JAK inhibitors in the transplant setting? It's not well studied at this point, but I think that we really can capitalize on their role in the peri-transplant setting. Currently, fedratinib is approved in the intermediate to and high-risk setting. Pacritinib may be a real benefit for patients who have low platelets, allowing us to achieve some of that JAK inhibition in patients who otherwise would be unable to due to their low platelets. And for patients with anemia, momelotinib may be a good option. And from the fact that pacritinib and momelotinib are both easier on the platelet and red cell counts respectively, these might be good options for post-transplant therapy. So the modern algorithm for transplant decisions in myelofibrosis is if you have a patient less than 70, first if they have primary myelofibrosis, you go through the DIPS and the MIP70 model, as those have both been validated in that setting. And in patients with secondary myelofibrosis, go through the MySEC model. Once you've determined that the patient has less than 5 years survival, then at that point, you look at the MTSS scoring system that takes into account patient-related factors, such as the donor's possibility, their KPS, and then that stratifies patients into different risk factors from there. So the MTS is probably not useful in the setting of patients who have intermediate 1 or low risk disease. It's much more applicable to patients who will be undergoing transplant, who you've already selected are going to do that. So to summarize, what do we do with these different scenarios? Reduction of spleen size can be achieved with JAK inhibition, splenic irradiation, or splenectomy. And there is more data coming out that suggests splenectomy may be a good option for these patients with a very large spleen. Improved constitutional symptoms can be provided with JAK inhibition, and some of the newer JAK inhibitors may be able to provide that constitutional symptom relief, even in patients who have low blood counts. And then optimal donor selection. In terms of transplantation strategies, selecting patients appropriately. And this is a really complex topic of how to select a patient, and involves shared decision-making between a physician and the patient. Consider high-risk molecular markers as an indicator to do a transplant earlier in the time course, such as DIPSS intermediate 1. And conditioning has to be carefully tailored to patients' age and comorbidities. And finally, post-transplant strategies. Monitoring molecular markers post-transplant may be a way to help assess minimal residual disease, and considering early discontinuation of immunosuppression or donor lymphocyte infusion at that setting, since we know that once they have overt relapse, it's a lot more difficult to achieve a good response. In summary, some clinical take-homes. First of all, transplant is a curative option for patients with myelofibrosis with good long-term outcomes. Patient and donor selection is very important. Timing and sequence of allogeneic stem cell transplant can be very complex and challenging in patients with myelofibrosis, and all available prognostic information and scoring systems should be utilized when considering this. The role of JAK inhibitors to reduce spleen size is not harmful and may actually be beneficial. And though in small numbers, peri-transplant JAK inhibitors look quite promising. Ruxolitinib remains the standard of care to use in patients with intermediate or high-risk disease with myelofibrosis, especially when the platelets are greater than 100. However, fedratinib is a strong option in patients, especially in those who have moderate thrombocytopenia, and should certainly be considered as a pre-transplant strategy to reduce symptom burden and spleen size.
Great. Well, Jean, that was a fantastic talk and really helps to bring us to some cases where we try to weave together both the discussion of where medical therapies and transplantation really intersect. I think a lot of exciting information coming out regarding transplantation. So thank you so much for walking us through that. So why don't I kind of present the case and then have you kind of walk us through some of the decision making here from your end, and I'll chime in. So
Great.
case one, 70-year-old woman, long-standing history of JAK2 positive ET, treated with hydroxyurea during the time of her essential thrombocythemia. But as things happen, this individual's evolved. 2018, platelets are now 140, slightly anemic, some leukocytosis with a normal differential, some splenomegaly. She had no constitutional symptoms. Bone marrow showed fibrosis, no increase in blasts, NGS showing a TET2 mutation and DNMT3A. So this individual started on a JAK inhibitor, or this individual, your options are a JAK inhibition, a clinical trial, observation, or stem cell transplantation. The risk scores, depending upon how one calculates the score for DIPSS, would be intermediate 1, with the negative factor being age. MySEC would similarly be intermediate 1, with a median survival favorable at 9.1 years. MIPSS, intermediate risk, median survival of 7.1 years. So, Jean, what's your first blush about this case?
Well, with a case like this, and obviously I didn't include a lot of the details that we would want to know, such as comorbidities, et cetera. In a patient who's asymptomatic, and really the only risk factor that she has for these different scoring systems is her age, I generally do not recommend moving forward with transplant, especially since she doesn't have any high-risk mutations that are noted. I would even question the need for a JAK inhibition at this point. She has some mild splenomegaly, but if I don't plan on moving forward with a transplant and she has no constitutional symptoms, I might just make her a little bit more anemic rather than giving her much of a benefit from it. I think clinical trials could be a good option, especially as some of these clinical trials may have some disease-modifying effects and can be used early during the course of myelofibrosis. But I think observation would also be a very good option for her.
You know, I'll chime in from my perspective. You know, these individuals, one, I really try to drill down on that no symptom piece. You know, I do find one, there clearly are individuals that don't have symptoms, which is fabulous. Two, there are some individuals that they've evolved into the symptoms so slowly that they don't realize how many symptoms they have until they're alleviated. So I will use one of our patient-reported outcomes forms, like the MPN-10 or the MFSAF, to really drill down into that. Two, I think I probably am a bit more aggressive based on age and the longer-term impact of JAK inhibitors to consider starting it in such an individual. You know, I think that their benefit probably extends beyond just the splenomegaly and symptoms. There probably is a benefit in terms of disease modification. It's difficult to quantify, but I tend to be a bit on the aggressive side. But I do have a pretty honest conversation with the patient. So I think that, again, the well-informed patient, there's the patient that tends to be very proactive and wants to have everything done. Absolutely trial or a JAK inhibitor. Whereas, you know, if you have the individual who really is much more medication adverse, really doesn't like to be on medications, you know, the approach with observation might be very reasonable. I do think shared decision making can be very helpful in these more intermediate cases.
Agreed. Yeah, it is very interesting how when you do the MPN-10 or the MPN-SAF, how many symptoms will present themselves. So I agree that's a really good strategy and one that I've started to employ.
A couple things you threw in a curve. What if it was a much younger patient? And what if you threw in the very concerning ASXL1? So first, Jean, how would that impact your management?
Well, I'm not sure that, I think I would still have very similar conversation with regards to the role of JAK inhibition, the role of observation, stem cell transplant. This patient would be considered low risk because the only risk factor that was present previously was age, and she wouldn't quite meet that age risk. So she would be low risk. Her MiSeq wouldn't be any different, and the MIPSS score also would not be any different. So in a patient like this, however, the ASXL1 is concerning. What I would do in this setting is we could, discuss the pros and cons of JAK inhibition that we talked about as with the previous patient. I may also consider using something like an interferon in a patient like this. However, I don't know that this alone, the ASXL1, would make me proceed with transplant, but it certainly would make me watch them more closely. And whereas a lot of times I wait till there's clear evidence that they need to move forward with transplant, when I see these mutations, once they start to see movement in the wrong direction, I really tell them it's time to pull the trigger. So if we start to see peripheral blasts, for example, if the hemoglobin starts to go down, even if they don't meet the criteria that bumps them up to a different category with DIPSS scoring, I would follow them a bit more closely and be a bit more aggressive of when I try to push them towards transplant. And a lot of this also does depend on the patient and their perception of it. Again, this is a shared decision-making process as we move forward. And the ASXL1, though, how it can be very concerning.
So we follow this individual, and now she comes back and, more problematic situation, bigger spleen, platelets 90, white count 20 to 23, 2% blasts, and now some symptoms. The molecular panel is the same. How does this impact now this individual, I guess, would be 72? How does that weigh into your transplant decision, Jean?
Well, if the patient is fit, I wouldn't consider 72 something that would make me not transplant the patient. I've transplanted patients above 70 with good outcomes in the past. So I think a lot of it relies on sort of the fitness of the patient, their comorbidities, et cetera. So assuming that this patient has no comorbidities and actually has a fairly good performance status, this is somebody who I would want to bring to transplant. Now, ideally, I would like her spleen to be a little bit smaller, so I would want to try to maximize her JAK inhibition as we do this. Factors that would really be contributing to how I would approach this are the platelets dropping, because that makes me a lot more nervous about a patient is when I see the platelets going down, and the blast. But I think that in general, this would be a patient who I would really be discussing transplant with. And presumably she didn't go 2 years sort of without being seen and come back. And she's somebody who I've been following along and discussing with her at a regular interval. When do we do transplant? What are we looking for? And different things like that. Because I think that education strategy is really important. So when it does come time for a transplant, you're not startling a patient. You're not shocking them. You basically sort of set the stage for this to happen.
Agreed. No, I think in many ways, this is the classic myelofibrosis patient, and certainly I think benefits from JAK inhibition. And if they don't have a good response, certainly second-line JAK inhibition. But I think, as you said, the issue of transplant's an important one. I found at 72, the patient's willingness or aggressiveness with healthcare really can be quite variable. So that's an important factor as well. I see some patients who are quite aggressive with their healthcare and have good fitness, and that might be a good consideration. But I will find, in particular, above the age of 70, there's many possible candidates who might prefer medical therapy. So let's go to case 2. Why don't you walk us through this case, Jean?
So this is a 60-year-old woman with primary myelofibrosis. She's triple negative, so she has no driver mutation. She has splenomegaly with a spleen that's 7 centimeters below the left costal margin, a hemoglobin of 11, platelets of 100, white blood cell of 22 with 1% blasts. Bone marrow biopsy shows 3+ fibrosis with no increase in blasts, but she does have an ASXL1 and an SRSF2 mutation. So the question here, again, would be observation, transplant, or JAK inhibition. Her DIPSS score, despite some of these things that look frightening on her history, is actually low risk, but her MIPSS score would be considered high risk, primarily driven by the triple negative feature, as well as the presence of the ASXL1 and the SRSF2.
You know, I think it's a great case that you put forward because it shows really some of the refinements of our prognostic scoring system. The DIPSS, I think, was a great start, you know, but we always knew that there were some low-risk patients who really did quite a bit worse, and intermediate was incredibly heterogeneous. You know, so when we did the first iteration of the NCCN guidelines, intermediate 1, we had everything from allo transplant to observation. Again, really broad. But as you have it laid out, I view that, again, this is an individual with much more concerning disease. Triple negative, those other somatic mutations. And again, although they don't cross the thresholds of driving prognosis, a white count of 22 is awful close to 25. The platelets are right on the border at 100. But this is the reality of the limit of some of these continuous variables where we give kind of a thumbs up or thumbs down in terms of prognosis. So I would agree, this is an individual that I would tend to be aggressive with JAK inhibition, but clearly would have visit with yourself when I was in Arizona, here in San Antonio with my good friend Paul Shaughnessy and his wonderful transplant team, or our transplant colleagues and brethren over at MD Anderson. Very much of a combined approach.
Yeah, I agree, absolutely. This is somebody that, despite her DIPSS score, that I would really be considering for transplant with all of those other factors.
So let's take one last variation here. Jean, why don't you walk us through case 3?
So this is a 58-year-old gentleman with primary myelofibrosis, diagnosed in 2018. He was calreticulin positive and IDH2 positive. He presented with splenomegaly, constitutional symptoms, a hemoglobin of 11, platelets of 125, white blood cells of 12, and he has no increase in blasts. He was started on ruxolitinib and had significant improvement in his symptoms, including improvement in the splenomegaly, as well as started to feel quite a bit better. If we were to look at his DIPSS score, he would get 1 point for the constitutional symptoms, and his MIP score would be intermediate risk with a median survival of 7.1 years. And so in this gentleman, he is already on JAK inhibition. The big question here is, do we consider moving forward with transplant in 2 months while he's still having a good response, or do we wait until the ruxolitinib stops working? And this is one of the challenges that often will present itself with patients. Often they'll make their own decision about it, but I think it certainly provides a challenge when thinking of timing for transplant.
You know, it's a good case in that this is really the struggle. You know, my takeaway is that transplant is not a great salvage regimen for myelofibrosis. That being said, you know, it certainly can be effective, but the likelihood is less. So likely the optimum time is while people are having an optimal response. But of course, then they have the most to risk. Now, in that analysis by CIBMTR that I was a part of, that Christina Gowan led with our CIBMTR colleagues, you know, intermediate 1 was that possible group that we consider. But it was by DIPSS that, as we have learned, is quite heterogeneous because of other molecular features. You know, so I think in someone like this, that interim monitoring with additional NGS, with other subtle evidence of progression, is helpful so that one could proceed with transplant really as soon as you get a sense that their clinical phenotype is changing. I saw a patient yesterday who's 46 with MF, who's doing well on medical therapy. And again, nothing driving a change. But, if any clinical evidence starts to change, very much would want to proceed with that change. But what about yourself? Clearly we've seen situations where we wish we would have pulled the trigger earlier on transplant. What do you think?
Right. So in a situation like this, sometimes I'm really surprised with how much the patient contributes to the decision. I do know in a setting like this, if we're going to watch the patient on JAK inhibition, I generally watch for things heading in the wrong direction. And to avoid them getting too anxious every time they get their blood drawn, I always tell them that unless it's a major change or we see change occurring over the course of 2 to 3 blood draws, we generally will not react to it. But in this patient, for example, I wouldn't wait until the white blood cell count is 25. I wouldn't wait until the blasts were 5% or the hemoglobin was 9. If I started to see things heading in the wrong direction, and again, it's more of a gestalt than I think an absolute number, I would really be talking about bringing them to transplant for that exact reason, that you don't want to miss your opportunity. Because once they've failed ruxolitinib, I think you're dealing with a somewhat different animal that's harder to achieve a good endpoint.
No, I would agree. My experience is that patients can be remarkably stable on a plateau phase. And once you really start to see evidence that they're losing that plateau, it's good to either move to second-line medical therapy, or move to transplant if that's really your next step. So, Jean, why don't you leave us with a final thought on myelofibrosis for 2021?
Well, I think the one thing that, if I'm going to impart any knowledge from this talk, I think the one thing to take into account is, first of all, it's a big picture you have to put together to make the decision about timing for transplant. It takes into account the patient, the donor, their molecular profile, what their symptoms are, but it also what's going on with their life. Where are they personally with this process toward moving forward with transplant? It truly is a shared decision-making process. It's one that I actually enjoy walking patients through, especially patients I follow for a while and then bring them to transplant, because I think you really have a lot of dialogue and you get to understand what things are important to them and really help them through that process. So, I think seeing patients early so you can start preparing them, and then working with the patient to come up with the right timing is a critical piece of this.
Wonderful. I'll leave folks with once a sense of hope, given the both favorable data that are coming out regarding transplantation, but also very much the improved prognostication that we have and a pipeline of very robust agents that I think are really going to impact the disease. A lot of room to hope, a lot of improved outcomes we've seen for patients with myelofibrosis, many exciting things moving forward.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/MME860. This activity is supported through educational grants from AbbVie, Bristol Myers Squibb, and Insight Corporation.